Welcome to 100 Days of NCLEX series, where every day we're going to be breaking down one important nursing topic in a simple way. Day one is going to be spinal cord injury. So look, the main idea, it's simple. The spinal cord is the communication highway between the brain and the body. So when that pathway is damaged, messages about movement, sensation, and automatic body functions may not get through normally. So the first thing I want you to remember is that the higher the injury, the more dangerous it usually is. Okay, so a high cervical injury will be affecting the arms, the legs, and most importantly, breathing. The phrenic nerve usually comes from C3 to C5. So when those levels are involved, the patient may have a weak cough, shallow breathing, or may need ventilator support. So before you memorize anything else, lock in this sentence. Higher injuries equals higher risk, and cervical injury means breathing comes first. Okay? Now, let's connect the injury level with what you may see in the patient. A cervical injury in the neck, okay? So this is the most serious area because it can affect breathing on all four limbs. That is where you may see a quadriplegia, which is also called paraplegia. A thoracic or lumbar injury is lower, so the arms are usually less affected, but the patient may lose movement or sensation in the legs and may develop bowel or bladder mobility and skin problems. So the paralysis terms are mostly for vocabulary. Monoplegia means one limb. Hemiplegia means one side of the body. Paraplegia means both legs or the lower body, and quadriplegia or tetraplegia means all four limbs. So on the test, do not just memorize the word, connect the body area that is affected. Next, complete versus incomplete injury. With a complete spinal cord injury, there is no preserved motor or sensory function below the level of the injury. In simple words, the signals are completely blocked below that point. So, with an incomplete injury, some signal will still be passing. The patient may have patchy sensation, a little movement in one area, or finding that are strong in one side and the other. Okay? So here's the trap. Incomplete does not mean mild, okay, or mild. A patient can have a very serious incomplete injury, okay? So the word only tells you that the pathway is not completely interrupted. So when a question says the patient can feel pressure in one foot or move one muscle group below the injury, you need to think this is incomplete, not necessarily minor, okay? All right, so now we get to the one biggest NCLEX trap, which is spinal shock. Spinal shock is a temporary neurological shutdown below the injury. Think reflex problems, okay? So the reflex disappear. The muscles are flaccid and movement and sensations below the injury may be totally absent. So the bowel and bladder may also lose tone, so urinary retention and bowel atony can occur. This does not automatically tells you that the injury is permanently complete, okay? So during spinal shock, the exam can look worse because everything below the injury is temporarily switched off, okay? The important sign that the spinal shock is ending is the return of reflexes. So that is the clue that the test will usually want you to see, okay? So when the reflexes are returning, that means that that is sign that is a sign that the spinal shock is ending. Okay. Now put signal shock and neurogenic shock side by side because the names sound similar but the problems are different. Okay. Spinal shock is a reflex and a motor problem. So think about absent reflexes and flaccid muscles below the injury. But neurogenic shock is a circulatory problem. The patient loses sympathetic tone, the blood vessels dilate, you have blood pools, which is just pretty much accumulation of blood in certain areas, blood pressure falls, and the heart rate may slow down. So the easiest memory line is this. Spinal shock equals that reflex is gone. Neurogenic shock equals to low and slow blood pressure and a slow heart rate. Okay? So if the question gives you flaccidity and absent reflexes, you have to think spinal shock. If it gives you hypotension, bradycardia, warm skin, you have to think neurogenic shock. Now, let's make neurogenic shock practical. Because the blood vessels lose their normal tightening signals, they are dilated. So blood pools in the body, blood pressure drops, and the patient may become confused or less alert because the organs are not being perfused well. So unlike many other forms of shock, the skin may be warm, dry, and flush early on, and the heart rate may be slow instead of fast. So your priorities are still ABCs. So keep the spine immobilized, support the airway and breathing, and monitor perfusion closely, okay? So IV fluids may be given, but this is a vasodilation problem. So we need vasopressors, such as norepinephrine, that may be needed, okay? Now, if the bradycardia is severe, atropine may be ordered. Now, we move to autonomic dysreflexia, and this is a true medical emergency. It is most associated with spinal cord injuries at T6 or higher. Something irritating happens below the injury, but the brain cannot properly control the sympathetic response. So the blood vessels tighten and the blood pressure shoots up very quickly. So the classic NCLEX picture is going to be a patient with a T6 or higher injury who suddenly reports pounding headache and has severe hypertension. When you look for the cause, you have to think bladder first, bowel second, and skin or body irritation third. So a full bladder, like or Kincaid Foley, or a blocked catheter or a UTI is the most common problem. Now, then you have to think on constipation or fecal impactation. So after that, you have to check for tight clothing, wrinkled sheets, pressure injuries, tight shoes, burns, or another sort of irritation. Above the injury, you may see flushing, sweating, nasal congestion, headaches, and bradycardia. Below the injury, the skin may be pale and cool with goosebumps. So the dangerous finding is the blood pressure. Now, when autonomic dysreflexia happens, the order matters. The first action is to sit up the patient upright, usually high Fowlers. You do not lay the patient flat because that can make the hypertension worse. So you sit them up, allow gravity to help bring the pressure down. Then you check the blood pressure and keep rechecking it frequently. So you also have to then after that you loosen tight clothing, binders, compression garments, or anything else that could be causing the irritation. Next, find and remove the trigger. So you start with the bladder because this is the most common cause. So look for any kinked or blocked Foley or a full drainage bag, bladder distension, or the need for catheterization according to the order or facility protocol. If the bladder is not the problem, then you check the bowel and the skin. Now, if the pressure stays dangerously high, a fast-acting antihypertensive may be ordered, so notify the provider or activate the appropriate emergency response if the episode is not resolving. The memory line will be head up, then you loosen, and then you check the bladder. Okay, heads up, loosen the clothes, and check the bladder. Now, this is a halo vest. A halo vest is used to keep the cervical spine aligned and prevent any movement, okay? So that helps prevent any movement while the injury heals, so you stay like this. So the big NCLEX point is that emergency wrench or Allen key needs to be attached to the front of the vest. So it may be needed by trained staff to release part of the vest if in case of an emergency to access the chest or to access the airway. So never pull the halo rods and never use the frame as the handle to move the patient. You have to lock roll the patient and maintain spinal alignment. Do not tighten loose pins yourself. That is done by a qualified provider or a trained team member, okay? Keep the vest and liner dry. You check the skin under the edges of the vest and inspect the pin sites for any redness, swelling, drainage, increased pain, anything that is not normal. So also, if to check for any loose pins or any neurological change, any of those should be reported. And memory line, the range, it should be on the vest, okay? Hands off pins and lock roll the patient, like, you know, you don't want to move the neck. Now, if this topic starts to feel like a lot, organize everything into 3 nursing priorities: breathing, align, and prevent. So, first comes breathing. This is especially important with cervical injuries. Assess the airway, respiratory rate, oxygen saturation, coughing strength, and breath sounds. So, be ready to support ventilation if needed. Second is alignment. Keep the cervical collar in place, maintain neurological alignment, and lock roll the patient as one unit, like one roll, one lock. Avoid twisting or bending the spine during the care and transfer. Third, you need to prevent complications. So watch for spinal shock, neurogenic shock, autonomic dysreflexia, skin breakdown, bowel and bladder dysfunction, DVT from immobility. Reposition safely the patient, inspect the skin, follow the bowel and bladder program, and use DVT prevention measures as ordered. The easiest way to prioritize is if the patient cannot breathe, nothing else actually matters, right? So then protect the core from more damage and prevent the complications of immobility. Now, let's lock in this board logic before we finish, okay? This is quick. So spinal shock means that the reflexes are gone. Neurogenic shock means low blood pressure and slow heart rate and warm skin. Autonomic dysreflexia means a T6 or higher injury with sudden severe hypertension and pounding headache. So the first action, you sit the patient, right? And the first trigger to check is the bladder. So for the halo vest, you keep the wrench attached and never pull on the rods. For a cervical injury, the priority is breathing. So that is the pattern that the test wants you just to follow, okay, and to realize. So do not get lost in every tiny little detail about these topics. First, identify which complication you're looking at, then you choose immediately nursing action that keeps the patient safe, okay? So that's it. That's day one, spinal cord injuries. Remember this big pattern: high injuries are more dangerous, cervical injuries put breathing at risk, spinal shock is a reflex problem, neurogenic shock is a low and slow, and autonomic dysreflexia is a severe hypertension in a patient with T6 or higher injury. When autonomic dysreflexia happens, sit the patient up and check the bladder first. Protect spinal alignment, keep the halo on with the range attached, and never ignore changes in breathing. Okay? Thanks for watching Nursing Mode, and save this review. Come back if you to check it before the exam, and see you in day 2.